Good evening, everyone. I'm Dr. Hina Singla, Program Officer of Vision 2020, based in New Delhi. On behalf of Vision 2020 India and R. Meenakshi Sundaram, I welcomed you to this webinar on cost effective outreach in eye care. We will run the session for an hour. Vision 2020 India has been organizing various webinars under its Knowledge Hub initiative. Let me introduce our resource person. R. Meenakshi Sundaram is working as senior manager at Arvind Eye Hospital, Madurai, Tamil Nadu. He has qualified with master degree in hospital management, started his career at Arvind in 1983 and completed his service more than 4 decades in the field of eye care management. I request R. Meenakshi Sundaram to take over.
Good evening to all, and thanks for the nice introduction about me. And the title is Cost Effective Outreach in Eye Care. Because the outreach program is a very common strategy to reach out the people in the community, and it is a very common practice in any developing nation to reach out the people. And first of all, I would like to thank Vision 2020, the Right to Sight India, for giving this wonderful opportunity, and also thanking Arvind Eye Care System for having given me a great experience in this field and sharing with you all. So, in order to brief about the objective of the particular session is helping the eye care service providers to think about how to manage the outreach program from the cost perspective, because normally we look at the performance in terms of the surgeries at the end of their period, maybe about a quarterly performance or 6 years or 1 year. We look at the performance, how many surgeries are done through outreach program. But normally we do not encourage cost monitoring practice periodically. So how to monitor the outreach program from cost perspective? That is one important objective of the session. The second one is how to reduce the cost of the outreach program so that the program may become financially viable, and helping the service providers to have an idea about what would be the budget for the period to organize a number of outreach programs. So these are the objectives of the particular session. So when we look at the objectives of conducting outreach program from eye care need perspective, but we have to look at some of the facts. In India, I think more than 100 million people in the 50+ age are suffering from blindness and visual impairment with the reference to the recent RAP study. And if you take that the population in 50+ age, the decadal growth rate is 25.1%. It's a very rapid increase compared to the normal decadal growth rate. So the 50+ population increase is indicating that the need of eye care in the community. In terms of people, there are about 267 million in this age group, and who are at the risk of blindness and visual impairment. And blindness or visual impairment, either bilateral or unilateral, consider the people vision. It's 25% more in female compared to the male, because the female are highly depending on the outreach program or any kind of a free service program at the base hospital. So it's very high in the female gender. And finally, the resources, it's not really matching where it is available and where it is need. And if you take that ratio, one ophthalmologist is there for 60,000 population, and the concentration mostly on the urban setting. So I think considering all these facts, we should reach out the people even after a 4 or 5 decades service in our country. And when we talk about the sustainability of the outreach program, that indicators can be listed out as the scale of volume, how that outreach program, the volume is gradually increasing year by year. That may be about 5% growth or 10% growth, but there should be a steady growth in that. And there should not be any kind of a compromise in the quality of service. The one important indicator is the best corrected visual acuity. That should be 612 or better. And whatever the resources we put in, that should be optimally utilized for outreach program. And that program should be financially viable. And we should move from cataract centric to comprehensive eye care in outreach program. And there may be some kind of methods to identify the patients using the technology. And the program should be expanded to the next boundary of the service area. It should be a scalable model. So these are the common indicators or very, very important indicators related to sustainable outreach program. In most of the places, it is not sustainable because of the lack of closely monitoring on the financial part. So at the end of the year or end of a period, what we see, we look at the performance and we see the budget, and it's very expensive. So better we can stop the program or we can reduce the program. So that kind of attitude is there in many places. But we have to look at from the financial part from the beginning, from camp to camp. So we can focus the subsequent slides mostly focusing on the financing part of the outreach. So we should have some idea about what are the elements are consuming the cost in outreach program. The first, before going to the details, there are some common methods are there in outreach program throughout developing nations. There may be a kind of a case finding using the field workers in the community, and the field worker taking some materials and traveling through motorcycle or van, okay, and to the remote villages and identifying the patients and referring them to the hospital. The other method may be camps may be conducted with the limited resources and they may be focusing on cataract problem alone. And some hospitals may have built the team in order to provide a comprehensive eye care program in the community that includes post-treatment segmented diagnosis also. So I think we should move to the comprehensive approach to all the people, those who have needless blindness. So I think the presentation mostly focusing based on this comprehensive camp experience. So the elements which are directly connected with the cost, the first one is gaining entry. It means we should have a very good understanding about the service area. So what would be our service area and what are the potential villages where we can organize outreach program so that the nearby villages in accessible radius can get the service. So that kind of knowledge should be there and we should gain entry to identify the village, identify the venue to get the permission to use the venue for the service. Then we have to design the promotion, how to reach out the people with the right content in the right time. So we have to decide about what are the areas to be targeted per outreach visit. Then the third one is once all these things are finalized, we should ensure the basic facilities are available in the campsite in terms of furniture, power, sanitation, volunteers, health, etc. Then on the camp day, we are taking the technician, ophthalmologist, and ophthalmic personnel. Of course, non-technical team also. They are going to the village for camps. That's human resources cost. Then the transport of the medical team to go to the village and back to the hospital. And OPD service that consumes a very small amount of consumables, maybe clinical and non-clinical supplies. And finally, the patients who are fit for surgery are taken to the hospital, operated them, and including follow-up services after 2 weeks or 1 month of surgery. So when we consider the cost, the first 3 costs, that gaining entry, promotion, and the facilities considered as pre-camp activities. Then on camp day, we spend on human resources, medical training, transport, and the consumables. That's the camp day activities. And once we bring them to the hospital, we have to look at the surgery and the post-op follow-up cases. So these 3 major activities are there. And the service provider predominantly spending on the pre-camp and camp day activities. And the surgery expenses is reimbursed by Government of India grant-in-aid scheme or insurance scheme or any kind of donor. That is not available. I think we have to charge from the patient because nothing is free in the world. We have to get some kind of support from any of the sources to provide the surgery. So now we have to consider about what is the nature of the cost. So pre-camp and the camp day cost is a kind of fixed cost. Okay, so that cannot be getting back. Okay, and the money we spend on inpatient service and post-op, it's a kind of variable cost. That is a cost per patient. So it depends upon the number of patients are admitted, number of patients are operated. So most of the things are under our control in the fixed cost. We can look at that. The camp, pre-camp and the camp day cost, we have to consider that is the amount spent to identify the patients at the community level. So how to identify how much we spend to get one cataract advised for surgery? So it's a very, very simple method of calculation. We have to calculate all the 6 costs and the denominator would be how many patients are advised. So that gives you unit cost, how much we have spent to get one cataract. And when we bring the patients to operate them and doing post-operative medication, that is called a cataract surgical cost. That is little complex process in terms of a calculation that can't be done for each camp. That can be done for a period of time, maybe about a quarterly period or 6 years or 1 year at organization level, mostly through accounts department. But the case finding cost, it's purely is very, very simple and it can be done for camp at a departmental level. So we focus on the case finding cost. So if you look at that budget to conduct a camp for the size of the 200 to 300 outpatients and roughly 20% of the outpatients can be admitted for cataract. So for this size of the camp, based on our experience, you can see the heads for pre-camp activities. The first one is the pre-camp visits, and the second one is the materials for publicity. Then mic announcement that really attracts more people for the camp, and the publicity execution cost, volunteer cost to do the publicity, etc. So that comes to about 14,000 rupee in Indian rupee. If you convert into US dollar, it's $165 for the pre-camp activities. And on the camp day, we need to spend about 17,000 rupees for the medical team HR, medical team transport, medical team food and refreshment, then lunch packets for the selected patients and miscellaneous costs. So that's about 17,000. So if you convert into dollar, it's about $203 are spent. So as a whole, if we add pre-camp and camp day activities, the budget is about 31,000 rupee or $368 need to be spent to conduct a camp where we can admit 40 to 60 cataracts. So if we convert into unit cost, I think we need to spend about 770 rupees to get one cataract advised and $9 to get one cataract for surgery. And here we have to understand, as I said earlier, the pre-camp activities and camp day activities cost is a kind of fixed cost. Okay, so it is becoming cost effective if the expectation is met. For example, we expect about 40 patients in this size of the camp. So the unit cost we discussed about 770 rupees and the US dollar is $9. So if there's a good work is done at the community level, there's a very good referral system, community involvement, and a very good overwhelming response in the community. Result of that, if you get 60 patients admitted, that cost comes down. There's a cost cutting off 33%. Okay, and something went wrong in the community. Publicity is not done properly, the content is not reached to people, okay, or we have failed to do good promotion, whatever it is, or we have not targeted the right potential villages, whatever it is. If the camp was very, very low productive, for example, if you admit only 20 patients, the cost becomes double. So we spend one more time. It's about 100% of the cost increasing. So whatever we spend, that may be cost effective, it's directly proportionate to the productivity of the camp. So now we can understand we can't reduce the cost much, but we can reduce the cost by increasing the productivity. So analyzing the cost is really alerting the team to concentrate on how to get the camp more productive so that the cost goes down. So, what could be the key strategies to attract right outpatients? There are kind of four C's to foresee the right outpatients in the camp. The first one is the community participation. Whoever may be there in the community, if anyone is interested or can be motivated to serve their own people, we should involve them. So identifying the right community partners is a big challenge that we should initiate it. Then what are the effective campaign methods and how to implement that method the right time with the right content and how to attractively reach out the people. So that's the campaign method is very, very important. Then the content part. In most of the places, sir, we get the patients, but don't get the patients with the problem. Or we get the patients not in the right age group. So all those things because of the content of the promotion. So where we need to give our focus. And finally, the coverage. What would be the right coverage of the potential villages? And what would be the targeted small villages for the main village? And what should be the accessible radius? Is it only 3 kilometer radius or 5 kilometer radius or 10 kilometers, whatever it is? So that we should focus on, that should be more practical rather than spending the amount for the long distance. How to focus very close the radius so that we can attract more outpatients. So this is the kind of 4C to foresee the right outpatients. So here you can see our hospital is a kind of service partner and a huge number of people gathering in an event in the base hospital to recognize the community partners service in the field of eye care. So you can see here there is a service partner and a community partner. And if I ask who can really attract the patients, I would say the persons who are engaged at the community level. So he is a kind of decision maker. He is a kind of person influencing the productivity of the camp. But they are assigned by the community partners. So we should understand whatever the resources we spend from the hospital, whatever the money spent by the community partner for the promotion and logistics, that the productivity of the camp is highly depending on the people who are engaged at the community level doing the promotion to reach out the people in the right locations. So that is very, very important. And the community is a very big resource. Whoever is available in the community who may be representing a well-known, reputed service organizations like Alliance or Rotary or any kind of spiritual organizations or education institutions or Chamber of Commerce or any kind of political parties or Mukhya Pradhan or our own satisfied patients. So whoever may be, money is not at all a matter. How to identify them and how to make them realize there's a need for outreach. So that is very, very important strategy for the outreach people, and we should use the community as a big resource to reach out more people. And because I have seen many hospitals do not involve the community at a deeper level. If the community wants the outreach program, they have the adequate knowledge about the geography and they know how to create awareness in the community. And they have a good trust among the people. And because of the trust, the attendance and acceptance will be increased. And if anything is wrong, I think they are really a good supporter for us to conduct a camp. And really, they are managing the cost by half. If you do not involve the community in outreach program and they're putting all our resources in the camp preparation, whatever the activity kind of pre-camp activities, it is very, very difficult for us to manage the camp. The acceptance by the local community would be difficult. The pre-camp preparation is very difficult, and the mobilization of all support services and the publicity campaign, everything is a very, very difficult task for the people. And if we involve the local community, we can organize the camp in a period of 1 to 2 weeks time. And they will manage or they will take care of at least half of the budget. Whatever I told, it's about 30,000. So approximately about 15,000 can be managed by them. The remaining 50% will be borne by the organization. Otherwise, we need to spend everything from our resources, our own money, and the camp will not be protected. So here the first important message is we should use the local community to make it more productive. That has a good impact in the cost management. And this is very, very important message we should give our attention where we need to focus the population. So what should be our radius of coverage for each camp? So there may be a selected potential village and having a number of adjoining villages. So rather than giving our focus to sporadical or very, very scattered areas, I think we should focus where we can expect the people, where the people can easily access our campsite. So that is very important because the promotion cost is very huge. That should not be drained to the untapped, inaccessible areas. Because the camp is not a regular activity. It's a kind of a temporary service. It may be conducted once in 3 months or 6 months or a year. So if you do not do the right propaganda for the right audience, the right potential people, we are really refusing the opportunity for the people. Again, the people have to wait for the next camp. So this is a very, very important step to make the camp productive. So once the camp is done, I think we should analyze what are the areas we have targeted and what are the areas we have done the promotion and where we got the patients. So this can give a real picture about how effectively we have reached the people. Either suppose if you don't get the right number of patients from the targeted villages, I think we need to correct ourselves in terms of publicity execution, either whether the content is not good or the period is not good or the method of publicity is not good. So whatever it is, that may be a good learning experience if we analyze their data after the camp. So this is the very important message to get more patients. So far we discussed about how best we can do at the community level. So as an eye care service provider, we have to think about how to design the strategies at the community and base hospital levels. So what we discussed at the community level, how to involve the local community, how to systemizing and effective publicity can be done, all those things we discussed. And we have to discuss about other part of the cost effectiveness at the hospital level. So what should be the screening protocol? What may be the selection criteria? And what is the design to complete the service flow? So that we can see in detail. So here we can see the table. We expected this one case study. So we expected in a camp about 200 outpatients and 20% to be admitted for operation. That is 40 cases. So we got it was 165 patients and 25 patients advised for surgery. So we are supposed to bring 25 patients, but the patients were not willing for surgery, were 8 patients. So there itself 32% of the advised are dropped out. Then we admitted 17 patients. So 68% of the advised only admitted in the base hospital. Then after we admitted, how many were operated for surgery? It was only 13. So 52% of the advised only operated finally. So 4 patients were not operated due to some reasons. The reasons may be valid due to systemic conditions or kind of a specialty opinion or some any personal reasons. So 4 patients were not operated for some reasons. That is about 1/4 of advised. So finally, if you look at the number, at least 48% of the people are dropped out, where we have spent the money to identify them. If you look at the case finding cost, we have spent 1,236 Indian rupee. Keeping in mind 30,000 rupees were spent by both the hospital and the local community. So as we are losing 8 patients as not willing for surgery, we have increased the case finding cost to 1,200 to 1,800. After we admitted, as we have not operated 4 patients, the case finding cost comes to 2,377. So imagine such a huge amount we spend one surgery for one surgery. Consider the budget, that's a cost spent already. So in terms of dollar, the dollar comes to $15 to $28 due to not willing and not operated. So we don't analyze the case finding cost for each camp. What happens, really we do not realize how much we have spent without benefiting the patient. So finally, because of the huge dropout, that is 12 patients or 48% of the advised, we have lost 14,800 rupees. That is close to half of the budget. That is a money value. That's a money value. So how to make it more effective? That we have to look at that. Okay, so the cost has raised from 1,200 to 2,300. Okay, due to the dropout at the time of admission, at the time of surgery. So how to reduce it? The effective publicity campaign can help us to get potential outpatients. Then selection criteria and proactive counseling at organizational part, that should be standardized. So we should have a standard selection criteria and how we can do the counseling. That counselors should have accountability to achieve 80 to 85% acceptance rate. Then that cost will be remaining. Then we have to look at whatever the possible pre-operative investigation like systemic case verification, blood sugar test, blood pressure test, all those things. If we do it at the community level, we can again reduce the dropout at the community level. And we should also focus on admission policy. Either we bring them on the same day or we are bringing them after 2 days or after 1 week, or simply we will refer them to come to the hospital. And how effectively we can bring them by arranging the transport facility so that all the patients can be brought to the hospital to reduce the dropout. That can be done at the stage of admission. So once we bring them to the hospital, we have to monitor the pre-operative waiting. The pre-operative waiting may lead unnecessary absconding, unnecessary refusal for surgery. So we should analyze what is the pre-operative waiting and what are the reasons for the not operated, either clinical or non-clinical. So if we focus on those 4 boxes, I think we can reduce the cost or we can maintain the cost without increasing the cost unnecessarily. So here I would like to brief what should be the take-home message. So at the community level, we should give our focus on how effectively we can do the campaign so that we can get the patients with the right age group in the right number from the right number of villages. And that is highly possible only by involving the local people. So the community partners are helping to get more patients they are managing the cost. And what we can do the best at the organizational level, we should concentrate on designing part, how to standardize the screening protocol, what should be the selection criteria, and what should be the admission policy, how we can arrange the transport to bring them, and what should be the counseling method, and what should be the accountability for the counselor, what should be the counseling audio visual aids, because high health education is very important. Patient is a decision maker. The patient, the counselor is not a decision maker. So we should help the patient to take a decision. So counseling can achieve that. And how effectively we can do monitoring part once the patient is admitted till the patients are discharged. And how to inculcate the cost containment practices at all levels. That's a kind of work culture that has to be inculcated from the top level by the management. And how effectively we are governing the program by introducing standard operating procedures, protocols, and monitoring and evaluation. So good governance only can help the people, can help the outreach team to identify the problems and to get the right solution to overcome it. So if we are having all these things in the right place, I think we can increase the productivity that can reduce the cost of the outreach program. And the unit cost also will be reduced. That can help the program more financially viable. And even at the end of the period, maybe quarterly or half yearly or end of the year, we can see how effectively we have spent our money and how effectively we can use the budget for next period. So with these things, I conclude my presentation, and thank you all for your listening. Now, if any questions, I think I can help you to understand. Thank you.
We have various questions. The first one is how to make outreach programs sustainable.
Yeah, sustainable. The two things are there. As I briefed, we should get the right number of patients, what we predicted. For example, if I expect for covering about 10,000 population, approximately percentage of the people should attend the camp, at least. So if I cover about in Thara region, I'm talking about that, not in a geographically difficult terrain. So in a Thara region, if I target about 10,000 population, I should register 100 to 150 outpatients, okay, in the right age group. Of that 100 or 150, at least 70 to 80% of them in 50 plus age group. Then definitely I can get the right number of people with that problems. So that's one thing. And it helps to reduce the cost, whatever we spend the money. And whatever we budget the amount for the pre-camp activities, that should be meaningful. How much we need to spend for the selected villages. We should not overspend on that. So two things can help us to make the program sustainable.
Okay. The next question is, does government support eye screening camps also by reimbursement?
The government of India really is supporting the free surgery. Predominantly the people who are operated through outreach program, and they are supporting each surgery with a free IOL at the rate of 2,000 rupees. So that is why I told that the suggested acceptable level of case finding cost may be about 600 to 700. Then only the organization can do the surgery with the reimbursement cost. They can manage that. Otherwise, they can't manage. If they spend more to get the patient.
Okay. Can we get sponsors for the marketing for the camps, like the pre-camp activities?
Definitely, I would say that should be kind of mandate, because the community should take ownership. Our founder chairman, Dr. G. used to say, the local person should take ownership of this social burden. Okay, so in fact, they should accept Aravind or any eye hospital. So please come to our village. I think you should help our own people, those who have a problem with the eyes, that may be kind of a blindness or visual impairment, because the people are not able to go to the field, they're not able to work in the field. Okay, and even at a productive age, and some of them are not able to save the family. So I think you should help our own people. We should make all the arrangements at the community level. So that kind of ownership should be initiated. So that's really, it's quite possible to identify the right philanthropist in the community. Money is not a matter. Only thing is that we have to approach and we have to educate, and they can support.
Okay, sir. Next one is the person said, sir, you mentioned that the hospital shares 50% of the cost. Is this to be paid to the community organizer? And if not, what would be the expense other than the transport cost?
Actually, the case finding cost does not include the transport cost of the patient. So whatever the money spent at the community level, we consider as a. Okay, so if you look at the budget, approximately it's about 30,000 for that size of the camp, where we can expect about 40 to 60 cataracts. If that pre-camp activities and a part of camp day activities taken care by the local community, it's alone about 50% of the budget. So if you recollect the budget I showed, pre-camp activities and a part of camp day activities, that is a hospitality for the medical team, that itself is 50%. The medical team HR cost, the medical team, transport, and consumables. It's another 50% of the total budget. So if we involve the local community to take care of the pre-camp activities, about 40 to 50% of the budget is taken care by them. And there is no any kind of a cash handling between the organization and the local community. So they take care of that activities, they spend for that. We do not get any amount as a donation and we do that. No, it is not at all our activity. We are only the service partner. The real owner of the camp is somebody else in the community. So if that is practiced, if that kind of culture is developed, I think half of the cost can be cut down.
Okay, sir. How do make our camps accessible, especially now that Nigeria is facing a very high economic challenge?
I think we should consider about, because the accessibility part, it varies from place to place. Even if you take India, some of the most of the areas we don't have any geographical challenging area. It's not a hill station. Some of the parts are hill station. And if it's a thorough region, I think we should consider what is the accessible radius. If I choose one potential village, I would say about 5 to 7 kilometers may be a reasonable radius where I can get more patients. If I target long distance places and if there is no good accessibility by transport, I can't get the patients. Okay, and similarly, we have to consider about geographical challenging area like a tribal or hill station. We have to consider the local conditions, how that a transport is accessible, how the facility is there, and how that the patients or how the people are gathering for any kind of market or purchase, whatever it is. Because that is why the local people having adequate knowledge than the hospital. So if you involve the local community, they can say, we can cover all those villages, the people can come easily to the camp village. So we have to involve the local people and choose the targeted villages where we can focus our promotion.
Sorry. Do urban outreach program is workable in tier 2 cities to raise the base hospital OPD?
Sorry, can you please repeat?
Do urban outreach program is workable in tier 2 cities to raise the base hospital OPD?
If I'm right, I think the question is, can we attract more footfall by organizing outreach in the urban areas?
Yes, sir. In tier 2 cities.
Normally, we do not encourage the outreach in a very close the radius of the base hospital. Otherwise, the people will be expecting the next camp rather than accessing our hospital. So that is why wherever we start our vision centers, that is the permanent eye care facility, we do not organize outreach program or we highly restrict in the outreach program. Because the people should be educated to access the service by themselves. Wherever the service is inaccessible by distance, or wherever the people are not able to pay for that, I think we can encourage that outreach program. So better, I can advise to target the rural areas. Mostly.
How to manage the camps when there are many eye hospitals nearby, as people tend to come less to the camps?
Yeah, normally we say, sir, a lot of competitors are there, a lot of hospitals are there. Really, we do not accept the word competitor. Okay. So, how a person either producing a product or providing the service can attract more people, more customers, only by strengthening two things. One is the quality of service. The second one is how do we deliver the service. So how to focus on quality of service and how to deliver the service to the people, and what we have designed to deliver the service in order to satisfy the patients, in order to meet the patients' expectation. The people will come automatically. That's a kind of pulling strategy. Rather than blaming others, how effectively I can do my own service, how effectively I can satisfy my own people by improving my own service. That's the very right approach to get more patients.
Okay. What are the major jobs of a community camp coordinator?
The major job, or I would say the major challenge for them is how to identify the right community partner and how to guide them to conduct the program. That is very, very important task. So here, it's a kind of the judgment capacity is very important. Who can really be motivated to do the service? That one important quality. So it's a judging capacity. The other one is very good communication and how to help the people, because I should not misguide them for overspend, or I should not misguide them to do unnecessary propaganda, different methods, various methods. So I should properly guide them, because the community partner can be satisfied if the camp is successful in terms of the beneficiaries. Others, they may not continue the program. So the organizer's main challenge is identification and motivation of the community partner. The community partner may have a different backgrounds, maybe may have a different profile. But the only thing is they should have a service attitude. That's the only thing.
Is the cost of transportation of the patient borne by hospital or organizers for the this camp?
We take care of the transport cost. From Aravind experience, I would say, because we do not give that burden to the local community partner. The community partner is organizing the camp, they provide the facilities, they help us to get more people, that's all. Then once we get the patients, I think that outpatient service and bringing the patients to the hospital, operating them, their transport, their food, their medicine, surgery, and the consumables, 1 month medication, and the post-operative follow-up, everything is by the hospital, not only RV, any service provider. Those who are getting the financial assistance from government of India, we should not charge from the patient. If government of India scheme is not available, or somewhere it is not available for some reasons and not getting, either I should go to the donor, I should get from the patients.
Okay. Role of AI in outreach programs in camps to assess the cost and monitoring statistics and prediction.
Role of AI.
Yes.
So far, we have not used that much technology in case finding mechanism, but a lot of devices are coming up now. How to use by a well-trained field worker at the community level to identify the patients are having problem like a cataract or even some of the other problems like a suspected posterior segment problems. So that the AI device is coming up. That device can be implemented at the community level by well-trained people, so that we can identify more people with the problems at their own. By using our clinical resources at a minimum level, we can get more people. So that can be done at outreach in a very short span.
Thank you. There is one more. How to identify community partners for paid camps?
For paid camps, it's a very, very small, very, very rare occurrences are there happening. Some of the places, the hospitals are going to some of the residential areas, some of the group of apartments, and they conduct a camp and helping the people to identify the problem. And they may refer the people to come to the hospital. So that kind of screening and the referral mechanism happening, and that is considered as a paying camp. So in that case, I think the service organization will not come forward. Otherwise, there may be a kind of a corporate tie-up or commission basis. If I organize a camp, if I mobilize the people, how much you may give for surgery, something like that. So that kind of services, I think we can involve that apartment, the residential area association. That association can help us to organize such kind of screening programs that can be conducted for the benefit of the working people.
Okay. Camps versus vision center screening. Can camps be conducted in vision centers?
Already told, we start the vision center with a different objective. The main objective of the vision center is a kind of universal coverage. the universal coverage of eye care for the defined population, that may be about approximately 50,000 population to maybe about another 70 or 80,000 population. We should have one vision center according to that Vision 2020 principle. So once we start the vision center, that should function throughout the week as 1 day holiday. And that vision center objective is to inculcate positive health seeking behavior in the community rather than waiting for a camp. So that's a basic objective. And a vision center can help the patients for any kind of periodical follow-ups. So when we have the vision center on organizing more camps, the people will not access the vision center and they may be waiting for the camp. So vision center cannot achieve its purpose. However, we continue outreach camps in some of the places where we have been organizing outreach for so many decades with some of the good community partners. So we could not deny, and it is a very, very rare occurrence. We do not encourage frequency. We organize 1 or 2 camps in some of the vision center locations. So we believe that won't affect the routines of the business. Otherwise, normally we do not encourage both services at one place.
So the next is, what are the criteria we need to check while hiring a community organizer?
The organizers should have a good communication skills and having interest to work in the community. That's very important. And we give priority to the people who have spent their educational social service or have done something in the marketing field, because they know how to approach the people. So we give the priority for the kind of a salesman quality, salesmanship quality. The main thing is how to identify a person in the community who are engaged in service and how to motivate them and how to guide them properly. So that kind of, because that person should be gel with their local community. That is very important.
Okay. Are eye drops prescribed in camps? And if yes, is it free or the patient has to buy?
We do not give free medicine. From Aravind practice, I can say we do not give free medicine. We prescribe the medicines, and sometimes in each camp we take also some of the samples. So the poor patients are getting their samples, but we don't sell the medicine or we don't give the free medicines for 2 reasons. So one is it is easily accessible wherever we organize a camp, and they can buy it. But one thing what we do before the camp, we give the list of medicines which are expected to prescribe by the ophthalmologist to the community partners. So that the community partner giving the list to the local medical shops to make the medicines available. And they can buy it. So we don't give free medicine or we don't charge for medicine. We don't do that.
Okay. In a cataract camp, if patient is having diabetic retinopathy, does the treatment of diabetic retinopathy be covered by hospital?
In our regular camp, we call them as a comprehensive screening camp. Whoever have a diabetes, we try to see the fundus. So we dilate and see the fundus of the patient. So if the doctor suspects any kind of posterior segment problems, we advise them to come to the hospital as a walk-in patient. Okay, and the patient may get free service as per the schemes are available. Because in Tamil Nadu, we have the Tamil Nadu Chief Minister Comprehensive Health Insurance Scheme. So that scheme helping the patient to get the service. And in each state, I think they may have some other scheme for also that I have heard about it. Okay. So we can provide free of cost. Or if the patient comes at their own as walk-in patients to the paying hospital, they can pay as a regular walk-in patients. But definitely we consider free or subsidized for diabetic retinopathy or any kind of tertiary care services.
Okay. Sir, there is one more question that, so you are running camp since long. How you encourage them? Did you feel short of camp organizers in some time?
Yeah, sometimes there may be a shortfall. Sometimes it is difficult to identify the right person. So we have to keep on. People may be there, but we have to identify.
Okay. Does training of junior doctors for cataract surgery done on camp patients? And if yes, is a consent got from the patient?
That's so mostly it's a kind of a academical part. So we have academic division. I think that junior doctors are also given as per the standard norms. So they have wet lab and they do their training at the wet lab and they do the surgery under the supervision of the seniors. So that's a kind of academic division. But outreach service is also giving a good opportunity for training the junior doctors and the junior team.
Okay, thank you, sir, for the wonderful and knowledgeable session. So we are about to conclude this webinar.
Thank you so much, madam, and others, Dr. Fanindra and other team members, and our own team members for giving this opportunity to share with the many people. Thank you.